Thank you very much for the introduction. We're going to change gears now and move away from discussing genomics and tumor selection to thinking a bit about the experience of receiving chemotherapy for our patients. Complications from exposure to chemotherapy may adversely affect quality of life in our breast cancer survivors. Therefore, studying the effects of chemotherapy is important to measure prevalence among survivors, to evaluate for risk factors predisposing to toxicity, and to continuously inform decision-making for a patient who's weighing the risks and benefits of receiving adjuvant chemotherapy. Over the next 20 minutes, we're going to review some of the major toxicities of chemotherapy with a focus on state of the science, management, and prevention. Before we start, I want to consider the words of one of our colleagues, Susan Love, who was quoted in the New York Times earlier this year. There is significant collateral damage from the treatment that is underestimated by the medical profession. There's a sense of, you're lucky to be alive, so why are you complaining? Well, I think our patients are quite grateful for the advances in chemotherapy, but it's important to think about their experience. This is a listing of common toxicities of chemotherapy, which are covered in detail in the accompanying manuscript in the education book. We will focus on the highlighted topics, and although we'll be discussing chemotherapy, I do want to point out that there's considerable etiologic overlap with endocrine therapy for many of these issues. We'll start with ovarian failure. Chemotherapy-related amenorrhea is a topic of significant concern for our premenopausal patients. The risk relates to age and somewhat to treatment. For our youngest patients, who are younger than 30, amenorrhea is relatively rare, but not negligible, with a rate as high as 20%. For women who are aged between 30 and 40, the rates can range between 20% to 50% and may reflect somewhat dose and duration of treatment. And for women older than 40, the risk is significantly higher, with some regimens as high as 80 or 90%. Amenorrhea may be temporary or permanent, and it's important to remember that ovarian function may return in the months or years following completion of chemotherapy. Therefore, amenorrhea is a poor surrogate for menopause and infertility. A patient can be menstruating and yet be infertile. Correspondingly, a patient who is amenorrheic while taking may remain fertile, may be ovulating, especially if they're receiving tamoxifen, which is notorious for causing menstrual irregularities. Therefore, accurate assessment of ovarian function has important implications. This is important for family planning, as if a patient is amenorrheic on tamoxifen, it's potentially that they could become pregnant and they need to think about contraception. Additionally, this is important for breast cancer treatment as we consider changes in endocrine therapy. Infertility is a related toxicity to amenorrhea, and this can be impacted as well by trends in longer duration endocrine therapy. Concerns over fertility may be substantial for our younger patients and may actually influence their selection of chemotherapy, or even if they're going to get chemotherapy at all. There are pretreatment options for fertility preservation. This includes cryopreservation of embryos or of oocytes, which require endocrine stimulation before starting treatment. Investigational therapies include preservation of ovarian tissue or the use of ovarian suppression during treatment. For a patient who's interested, referral to a specialist with expertise in fertility preservation is recommended. This is some recent data looking at the idea of ovarian suppression during chemotherapy for ovarian protection. These are two small randomized studies, one from UCSF, one from the German Breast Cancer Group, in which premenopausal women receiving neoadjuvant anthracycline therapy were randomized to receive ovarian suppression with an LHRH agonist or not. The women who received the treatment had no improvement in resolution of amenorrhea with either study, so both were negative trials. There have been some smaller studies with conflicting results, but at this time there's no evidence that this is helpful. We do await results of SWOG 0230, which is also addressing this question. Menopausal symptoms are quite prevalent in our breast cancer survivors and can be burdensome as well. This includes side effects such as hot flashes, night sweats, vaginal dryness, and dyspareunia. These can be ameliorated with supportive medications. However, these really reflect profound estrogen deprivation, and it's important to remember that providing back systemic estrogen in general is discouraged. There are many non-hormonal options to treat hot flashes listed here. On the left, you'll find agents which have been found to be useful in randomized placebo-controlled trials. This includes medications such as vitamin E, SSRIs, SNRIs, and even acupuncture. On the right side, you'll find agents which are not useful, either not useful in trials or with too many side effects. For example, clonidine has shown benefit in trials, but has many more side effects compared to some of the more modern agents. And some important clinical observations. For many women, hot flashes just get better with time and will resolve within a few months. Additionally, there's a well-documented placebo effect for any of these interventions, so it's important to just try something in a patient and see if it works. Sexual dysfunction is also common after chemotherapy. This can cause considerable distress and negatively impact quality of life. This can be related to chemotherapy exposure, primarily through amenorrhea, but also can be related to several of our other breast cancer therapies, as well as psychologic distress, including depression or anxiety. This is not often discussed in clinic, although there are effective interventions which exist. I'll point out the recently released NCCN survivorship guidelines include a 5-question checklist that can be easily used in clinic to screen patients for sexual dysfunction. Treatment may be multifactorial and often considers a multimodality approach, including biologic, psychologic, interpersonal, and social cultural influences. This may include the use of water-based vaginal lubricants for dyspareunia, vaginal dilation for stenosis, psychotherapy or couples counseling. There's also interest in medications for low libido. For those of you who read the New York Times Magazine, there was quite an article about this last week. Unexcited, there may be a pill for that. And there appears to be a growing pharmaceutical industry to support this as well. There's also interest in the use of vaginal estrogens for genitourinary symptoms, particularly dryness. If we consider that systemic hormone replacement therapy is not safe in these patients, what about providing local therapies? Well, this has been studied, and when we provide local estrogen therapy, as seen in the figure on the right, there is some systemic absorption, shown in the yellow bars. However, these levels tend to fall with time as atrophic tissues heal, and patients who are trying local hormone replacement therapy may experience substantial improvement in quality of life. It's not known whether this small and transient increase in systemic estrogen has a detrimental effect on risk of recurrence. We do have a little bit of data on this. A recent case cohort analysis from the United Kingdom looked at 10,000 patients with a history of breast cancer, 1,000 of whom had had breast cancer recurrence. And in this analysis, women who were using local hormone replacement therapy did not seem to have an increased risk of recurrence compared to those who were not. And I'd point out this included women taking tamoxifen or aromatase inhibitors. Certainly more data to support the safety of this would be desired. Neuropathy is a common toxicity with chemotherapy. There's many chemotherapeutics which can cause neuropathy, mostly the taxanes, and the incidence with adjuvant chemotherapy can be quite high. With paclitaxel, as high as 80%. Rates are somewhat lower with docetaxel, about 60%, and about a third of patients can develop painful neuropathy. As you can see in the figure on the right, the incidence of sensory neuropathy with weekly paclitaxel is fairly monotonous with cumulative dose and duration of exposure. Neuropathy can get better with time, but it's not uncommon for patients to have residual permanent neuropathy, which can also impact quality of life. For those of you who are treating patients, you may notice an interesting clinical phenomenon. Some patients you treat with taxanes will have absolutely no neuropathy, whereas others will become immediately incapacitated with debilitating neuropathy. So why are there these individual differences? There's been some recent interest in pharmacogenomic analysis to see if gene polymorphisms potentially could predict increased risk of the development of neuropathy. There have been recent analysis from 2 cooperative group studies, ECOG 5103 and CLGB 40101, both of which use paclitaxel, and these have identified candidate genes, shown below, where polymorphisms may be highly predictive of the development of severe neuropathy. This is really interesting data and definitely requires validation. It's also important to note that experiencing neuropathy is not associated with breast cancer outcomes, and neuropathy itself is not a marker of getting benefit from therapy. This opens the idea of potentially in the future using pharmacogenomic analysis to identify those at risk of severe toxicity and perhaps sparing them exposure to these drugs. Treatment for neuropathy can include a variety of different agents, although there's not much evidence to support their utility. There's also interest in the use of duloxetine for painful neuropathy, and this year we saw publication of a small randomized trial where patients with painful neuropathy were randomized to receive a 5-week intervention with duloxetine versus placebo. Patients receiving duloxetine had a 60% reduction in pain scores, although I would point out that patients who were receiving placebo, a substantial proportion, also experienced improvement. This might indicate a placebo effect or just that these symptoms can get better with time. Neurocognitive dysfunction has long been recognized, and patients have reported to us experiencing chemofog or chemobrain after breast cancer treatment. This is typically characterized by problems with attention, memory, and concentration, and can affect up to 3/4 of patients. There have been some recent studies that have been highly informative. A meta-analysis pooled over 800 patients, evaluating them at least 6 months after finishing chemotherapy, and confirmed small but significant deficits in verbal and visual spatial ability, so measurable changes were seen. Additionally, prospective studies have identified that cognitive changes can be detected before the start of chemotherapy, and this actually suggests that this condition may be multifactorial in nature, not just specifically from chemotherapy exposure. This is recent data shown at San Antonio this year from the group in Michigan, a prospective study of patients receiving chemotherapy, radiotherapy versus healthy controls. Patients had a functional MRI before and after their treatment, as well as extensive measures of cognition and fatigue. Cognitive dysfunction was observed in the breast cancer patients versus controls, and this correlated with changes on functional MRI. However, this also correlated with scores on the fatigue scales, and it was present both before and after treatment, again suggesting that there may be a multifactorial etiology that goes beyond chemotherapy exposure, considering anxiety and psychological distress, fatigue, menopausal changes, and other aspects of multimodality therapy. Other identified risk factors include older age, lower baseline cognitive reserve, and possibly some genetic polymorphisms, including genes that are more commonly associated with Alzheimer's disease. In the figure below, you can see the interaction between age and cognitive reserve. On the left panel, these are patients who had lower than baseline cognitive reserve, and on post-treatment testing, the older patients shown in blue had a decrease in their processing speed. This was not observed in same-age patients who started with a higher baseline. Management recommendations for cognitive dysfunction have been published by the International Cognition and Cancer Task Force and are also included in the new NCCN survivorship guidelines. Cardiovascular toxicity from breast cancer therapy is complicated, as many aspects of our treatment can affect the heart. Chemotherapy can affect the heart in several ways, and this goes beyond standard congestive heart failure to include coronary artery disease, vasospasm, heart attack, arrhythmia, pericarditis, and myocarditis. Anthracyclines are the most commonly implicated chemotherapy, and the risk is associated with cumulative dosing. At doses below a threshold of 550 milligrams per meter squared, the risk is thought to be less than 5%. However, past this threshold, the risk rises dramatically. It's important to note that when we give classic AC chemotherapy, this reaches a threshold of 360 milligrams per meter squared, far below the threshold. The lower rates of toxicity at low cumulative doses may reflect the fact that the heart has fantastic compensation and reserve for subclinical damage. Outcomes vary with time of presentation. Early onset cardiotoxicity is more closely linked to cumulative dose, more likely to be irreversible, whereas late onset may reflect this idea of sequential hits to a vulnerable organ. For example, a patient who receives anthracycline treatment years before and then develops a viral myocarditis and presents in clinical congestive heart failure. Treatment includes standard CHF medications, which can often lead to cardiac remodeling and improved survival. In clinical trials, rates of cardiac toxicity can appear quite low, and this may reflect that clinical trial patients are highly selected. What are the real-world long-term cardiac risks of anthracyclines? We saw an important paper published recently, a SEER review of 43,000 older patients with stage 1 to 3 breast cancer, 5,000 or so of whom received adjuvant anthracyclines. This was a community population, so these patients were older and had more comorbidity than who we see in a traditional clinical trial. In this analysis, the younger edge of the spectrum, ages 66 to 70, had a 26% increased risk of CHF for those who got anthracycline versus not. And as you can see in the figure on the right, this risk increased continuously over the 10-year period of follow-up time. Interestingly, the older patients, ages 71 to 80, did not have a higher risk with anthracyclines, although this may reflect some element of selection bias, as it's a special 70 to 80-year-old who's receiving chemotherapy. Risk factors for congestive heart failure are listed below, and I'd point out these include many of the classic cardiovascular comorbidities. Again, this suggests that there may be some baseline impaired cardiac reserve in these patients, sensitizing them to toxicity from anthracyclines. As we well know, trastuzumab therapy can also lead to cardiac toxicity, and rates of clinical cardiac events in the adjuvant trastuzumab-based regimens have been well described. I would point out that risk factors for cardiac events with trastuzumab also include older age, lower baseline cardiac testing, and cardiac comorbidities. And this again raises the idea that if we can identify from the beginning patients who we think are at high risk of cardiac toxicities, they could be selected for a less cardiotoxic regimen, or partnering with primary care and cardiology, pursue risk factor modification. There's been interesting work looking into other markers of cardiac toxicity risk. This includes imaging, as echocardiographic findings beyond the basic ejection fraction may also predict risk. This includes very sophisticated imaging, including 2D speckle, strain, and tissue velocity imaging. And these may be more consistent and predictive than just LVEF. Additionally, there's interest in cardiac biomarkers and whether post-treatment testing, specifically of cardiac troponins, might be predictive, possibly selecting patients for a medical intervention. There was a small study published, about 100 patients who had an elevated troponin after chemotherapy but a normal ejection fraction, randomized to a year of ACE inhibitor versus not, and those receiving ACE inhibitor had less evidence of cardiac dysfunction in that year of observation. And finally, there's also interest in pharmacogenomics to predict cardiotoxicity. This is data from pediatric populations, 400 children who received anthracyclines and then were followed for 20 years. A comprehensive genomic analysis was performed to construct a prediction model. Those who scored high or intermediate on the prediction model had a substantially increased risk of cardiac toxicity compared to those who scored low. And so again, can we identify those patients at risk and modify our therapeutic choices for them, or offer an early intervention? Finally, the most rare complication of chemotherapy is secondary malignancy, traditionally myelodysplasia or acute leukemia. There are two traditional patterns that can be seen based on the etiologic agent. For topoisomerase-related disease, this tends to present earlier without an MDS prodrome. For alkylating agent-related disease, this can present at least 5 years out and may be preceded by MDS. Rates of MDS and acute leukemia in clinical trial populations, such as in the NSABP, have been reported to be as high as 0.49% at 8 years follow-up. Again, these are highly selected patients. What are the rates in the general population? We had two recent analyses in the past few years. A review through the SEER analysis of 65,000 older breast cancer patients, 10,000 of whom received chemotherapy, suggested a slightly increased leukemia risk. At 10 years, 1.8% in those who received chemotherapy versus 1.2% in those who did not. In the NCCN, we saw presented this year at San Antonio 20,000 patients, 51 of whom had leukemia, and a cumulative incidence with chemotherapy exposure 0.52% at 10 years. I would point out NCCN does not capture MDS, so these numbers are not exactly comparable with what we looked at before. And so chemotherapy exposure may slightly increase risks of MDS leukemia, although overall this remains an extraordinarily rare toxicity. Again, the risks of MDS are not well reported. The contributions of growth factors or radiotherapy is less clear. And the rates of secondary disease after non-anthracycline regimens, such as TC, are less well described. So as we reach the end of the three lectures in this session today, I think it's important to consider our chemotherapy decision-making as a balance between risk and benefit. As you've heard from my colleagues, greater use of genomic testing allows a precise focus on treating exclusively chemotherapy-sensitive disease. However, the absolute anti-cancer benefit from chemotherapy is modulated by tumor features such as size and lymph node status. Personalized toxicity risks for a patient are constant, whether we're treating a small lymph node negative cancer or a locally advanced stage 3 cancer, and we need to weigh this balance for each individual patient. So in conclusion, adjuvant chemotherapy can lead to significant short and long-term side effects for breast cancer survivors, and the effects of chemotherapy can vary in severity but may negatively impact quality of life and overall health status. The management of long-term chemotherapy-related toxicity involves screening for symptoms, using supportive medications, and referring for specialty consultation when needed. There is significant ongoing research evaluating the etiology of toxicity, risk factors for development, and effective interventions. Our decisions regarding offering adjuvant chemotherapy must consider the toxicity risks weighed against potential anti-cancer benefits. And I would state the best way to avoid toxicity is to avoid chemotherapy altogether. Attention to toxicity-related concerns in our survivors and coordination of their multidisciplinary follow-up care is imperative and necessary for all of us. Thank you.